And it's really it's a huge pleasure to have Ricardo Araya here with us. I've known Ricardo for many years and been a huge fan of Ricardo and his work. So Ricardo is a professor and a director of the Center for Global Mental Health at King's College in London. And he's a leader in global mental health research, done really a lot of the seminal trials on evaluating affordable interventions for mental health problems in low resource settings in Latin America, Africa, Asia. And Ricardo has really gone back and forth between London and his home where he's from in Chile. So he got his medical degree from the Universidad de Chile, and then moved to the Maudsley in London, where he got advanced training and spent the early part of his career there. Then he went back to Chile for a few years, where he was the senior scientific advisor to the Ministry of Health, and then returned to the UK and has spent time as faculty at the University of Bristol, then in the Global Mental Health Program at the London School of Hygiene and Tropical Medicine, and then a few years ago moved to King's College, where he's now directs the Global Mental Health Center. And I think what's really been impressive to me about Ricardo's work and the way that he approaches his research is that he always has his eye on the end game. That when he begins even thinking about developing an intervention, he's thinking about the eventual implementation. And he's really was thinking about implementation science before there was even a term implementation science, and thinking about what would have to happen with policy for it to be implemented. And as a result of that, his research, for example, his trials in Chile validating the treatments for depression have been adopted as the national depression treatment program in primary care in Chile, and that program has now been adapted and replicated in a number of countries around the world, including India, Zimbabwe, Nigeria, Colombia, Brazil, Peru, and Lebanon. So I think he's really been a leader not only in the research, but also in really moving the needle on the delivery of mental health in low and middle income countries. So it's really a pleasure to have Ricardo talk to us today, and focusing also on his movement now towards the utilization of digital tools for the delivery of mental health. So Ricardo, I'll turn it over to you. It's a pleasure having you here.
Thank you so much, David, for your very kind words. I'm really impressed how much you know about me. There are things that I didn't even know myself. It's good to be reminded, because I want to tell you a little bit about my journey and how I'm not an expert in digital mental health, I must admit, from the beginning. But what I want to tell you is what was my journey? How did I become interested in digital mental health? And I think it's like what David was saying, is that you're just trying to think that there is a problem that you need to solve, and what are the ways? I mean, what are the factors that are leading to that problem? Now, what is the way out of that problem? How do we overcome that problem? And this is how I became interested on this. But I'll tell you a little bit about how I came to this. If I can move my slides. Oh, okay, I'll use this arrow. So first of all, to say that, if there is something I've done, is that I've tried to concentrate most of my work in low and middle income countries. I have done quite a few things here in Europe as well. But my heart has been in low and middle income countries, in resource poor settings. And one thing to say about that, just for those of you who are not very familiar with this sort of stuff, and if you are, my apologies, but just to say that, mental disorders had been increasing over the years. This graph only goes to 2016. And what you can see that almost everywhere in the world, mental disorders have been increasing. But that is even particularly more pronounced in low income countries, as you can see in the bottom line here. So these are very prevalent problems. The second thing to say, even though that they are very prevalent, the terrible thing to say is that there is, I put in here, mind the gap. For those of you who've come to London, when you go into the underground, they usually remind you, mind the gap, which when you are disembarking from the train, you know that you're not going to fall into the rail track. But mind the gap, because there is a massive treatment gap, but it doesn't only affect low and middle income countries. These inequalities are obviously more pronounced globally, but there are also massive inequalities within countries. And the US doesn't escape from that rule. Almost in every country, you will see that. But what I chose to highlight here, it was the difference at a global level. What you see is that, roughly 1 to 2 out of 10 people in low and middle income countries with a mental health problem receive any kind of treatment, whereas in richer countries, high income countries, 5 to 6 out of 10, roughly, do get some kind of treatment. So even though low and middle income countries do have a problem, also think about your own patch that there are inequalities, there is a treatment gap in the US as well. Now, what low and middle income countries have in common, which I used to say it is the common denominator, it is the lack of resources. And this is why we call them sometimes, resource poor settings. And when I say resources, I'm talking about any kind of resources. But one type of resource that is very important when delivering mental health interventions is the human resource, especially the trained, specialized human resources. And what I just want to show you roughly here is that doctors and psychiatrists are, is a kind of a rare commodity in most low and middle income countries. And when you think about inequalities within countries, you will find also that within countries, there are certain areas within your own country where it's more difficult to find doctors and psychiatrists. For instance, I know that in the US, in more rural areas, there is a lack of specialized resources. But roughly, what you see is that Africa and Asia are the parts of the world where doctors are very, rare commodity. Now, what I wanted to show you in here, which is reflecting on the same, but basically, I'm not really interested in what you see here. What it is important here is what you don't see. And what you don't see is the bar for the low-income countries. For any of the categories, psychiatrists, psychologists, psychiatric nurses, social workers, there's virtually none of these in low-income countries. And that is a major problem because, as I said before, when we deliver mental health interventions in the traditional way, it's, the human resource is a key component for this. Now, just to share with you a couple of things, like for instance, in a conversation with my friend Bikram Patel, once he said that India produced around 100 new psychiatrists per year. Most of them actually leave the country to work overseas. But for India to achieve equivalent rates of psychiatrists as the US, if they were to go at the current training and retention rate, they will need roughly 2,000 years. No much of a solution there. My friend Oye Gureji said to me one day that there were more Nigerian psychiatrists in New York than in the whole of Nigeria. So there are some pretty hard facts in there that suggest that the specialized route is probably not the way forward. Many years ago, I came across with this paper in The Economist. I think it was in 2012. It's there, June 2nd, 2012. And it was basically about squeezing out the doctor. And the idea was, what is the role of the doctor in the future healthcare system? And as you can see, it's the idea of squeezing is in the picture is quite clear. And the paper, was basically about the US. It wasn't about low and middle income countries, which is what attracted my attention, really, because it talked a lot about physician assistants in the US. And it said that, about 85% of the work of a general doctor can be done by a physician assistant, which was quite a surprise to me. And he went on to say that, we should think more strategically and resources should be reallocated. That nurses and other health workers can use the training in a better way, and doctors can be, allocated to other tasks which are more complex and worthy of their highly trained abilities. I'm not so sure that they are highly trained abilities, but, I did get the message. I did check, and I've kept an eye on, the numbers of physician assistants in the US. And this is from 2016, but the numbers are increasing rapidly. And the more I read, it says that, one of the most sought after jobs, because it is very well paid, is to become a physician assistant. So the whole idea is beginning to happen. And so essentially, it was one side of the picture that you saw before from The Economist. Now, to me, that was really interesting because we had been doing this thing, the task shifting idea, for longer than 10 years, probably 15 years before I saw the article in The Economist. And my first reaction was, why does it take so long for some countries to react to something that, for whatever the reasons, because I think the reasons why we chose this route in low and middle income countries, it was because we didn't have resources. I think the reasons in the US and here in the UK to follow this route, it is to do with cost savings more than anything else. But whatever the reason, that the route is there, and we had accumulated experience, knowledge, research for like 15 years by the time when I read the article. So it was an interesting thing that made me think, knowledge shouldn't always follow, north to south. And there is an opportunity from south to kind of, share some of what the things we've learned with north. So task shifting or sharing, which is a more politically correct expression these days, is when specific tasks are moved, when it is appropriate, of course, from highly qualified health workers, specialized health workers, to other staff with shorter training and or fewer qualification, in a way that we improve the efficiency with which we use existing resources. Obviously, it requires that these people receive appropriate training, support, and supervision. And I just want to underscore this because it's really important and very often neglected. So in a nutshell, essentially it is, replacing, or perhaps not, I should have changed that because doctors get a bit itchy when they see the word replacing. Who is going to replace me? How am I going to be left unemployed? No, it's not replacing. It's actually having the option of doing the tasks that doctors can do by other people. Like in this case, the first port of call for us were nurses and social workers, actually. But then, nurses became another rare commodity. They were kind of, better opportunities for nurses from abroad, and, they began to migrate. And so we needed to think very quickly, who else, who do we have? The whole idea is just to think, what are the resources, the existing resources, and what can I do with them? So nurses, some of the duties were transferred to auxiliary nurses to community health workers, and community health workers to community leaders or teachers or parents or peers, and eventually we may even need to invite the fellow here on the right-hand side of my screen to help us with this business. But that's the idea. So I've been involved, as David said, in so many of these things. I just put in here a few just for you to get an idea what we're talking about. So on the top left-hand side, it was in Colombia, in an area which was very much affected by conflict and war. On top right-hand side is in Guatemala, in a rural area close to the Mexican border, where they have a more sort of traditional indigenous way of dealing with life. And the women you see in the middle, they're called comadronas, and they're essentially, you can translate that into popular midwives. And so they were there, they wanted to work, they were concerned about the mental health of the pregnant women that came to see them. And so they wanted to learn certain things, and we did a project with them, and it was an amazing experience and learning for me. At the bottom, you have on the left, Brazil, where I've done a lot of work. And there is a fantastic primary care system. All those people that you see in there are community health workers. One interesting thing about community health workers throughout the low and middle income countries is that most of the community health workers are females. As you can see in that picture, there is only one male, and on the one above, in Colombia, only one male. Well, obviously the midwives were all females. And on the right-hand side, it's a project that we completed we published the paper in 2016 in Zimbabwe that became quite famous now. It's called the Friendship Bench, and it became famous because most of these women are lay health workers, and many of them are actually grandmothers. And my friend Dixon has been kind of leading on that side. I mean, all these interventions have certain things in common. There's a very small role for doctors. Most of the treatment is delivered by non-medical health workers. The interventions are by definition simple, low resource intensive, because there is no other way. And they're all targeting socially deprived populations. Now, the results of this sort of task shifting to other health workers have been quite incredible, actually, very successful when we do randomized control trials, and in many different countries. We started the journey with the one we did in Chile, which in fact, it was a lot of it was an adaptation of a model that had been tried out in Seattle. Wagner and Wayne Caton and Greg Simon and Judith Unatzer, they had developed this sort of collaborative care model, which we adapted and we tried out in primary care in Chile with some changes to make it suitable for our local setting. And then we adapted again, and in India, from there we moved on to other places. We moved to Africa, Nigeria, and so on and so forth. So in terms of efficacy, it has worked. But like many other things, the real test is when it comes to implementation. And I have to say that, our intervention is one of the few that has actually been implemented in a large scale at a national level. But there are many examples of that. Many of these sort of randomized control trials, in the end are left in there. And it's just really sad to see that there is evidence And for a number of reasons, it's just not moved on and become something useful for the populations. So it really shows that scientific evidence is just one piece in the puzzle. There are lots of other things, and we've published about this as well. There are lots of other things which are a lot more important when it comes to implementation. And I know that David has become a bit of an expert when it comes to digital mental health interventions, implementing them. Now, there are lots of problems with this sort of, task shifting to other health workers. I mean, if you just simply concentrate on community health workers, I mean, what is happening is they're overloaded with so many other duties, they're there and everybody is kind of trying to use them. So it's basically, they just can't take no more. Many of them are not properly rewarded, and even, I will say, not even recognized for what they do. They don't get good training, they don't get support, and hardly ever are supervised. So it's not a great job, but for some reason they do it, and they do it rather well. Or besides that more kind of sort of community health worker related problems, there are other issues. There are powerful groups that are opposed to the transferring tasks to other members of the team for a number of reasons. There are tensions within teams when things are being reallocated. And the system don't help either, because in most low and middle income countries are disjointed and poorly coordinated, not only among providers, but also with different levels of care. So it's not easy to do these things, but it is working. And at that point, when I was thinking, how much further can we go into this task shifting to human resources? I mean, at one point we were going to be left with nobody really. So then I began to think that was, when things began. Well, I guess we're getting a little bit hotter on the technology side, say 20 years ago. And that's the other side of the picture from the economists, which is, I call it task shifting to technology, because that was the idea that we had. Okay, why don't we try to transfer some of these tasks to technology, not only just in terms of treating people, but also in terms of supporting our health workers. So either way, it could help with the problem. So we started trying out different things. I'm just going to show you 2 or 3 examples. There are quite a few others, but just to give you an idea of the sort of things that we're doing. This is my colleague and friend, Marcia Skasufka from University of São Paulo, Brazil, where we were doing a randomized controlled trial for depression of elderly people in very, very deprived areas of the city of São Paulo. And basically, we decided that the intervention was a community intervention. There were community health workers that they were going and delivering the intervention at home, because there were elderly people in the kind of in the shanty towns, they're called favelas there. They have a lot of difficulties to move about, not only in terms of the limitation, their disabilities, but also because of security issues, because of money, to access services and so on and so forth. So since the community health workers have to go and visit all elderly people regularly in Brazil, we decided, why don't we just train them? And when they go, they can screen and see if they can help those that turn out to be depressed. And so we thought, well, how can we use technology here? So we decided we develop an app. And this app has certain functionalities. The main one, I think, or the one that it was best received by the users, it was the one that assisted the delivery of the intervention, in which we had a number of materials, videos, perhaps not even videos, there were animations. For each one of the sessions, there was an animation, and they were all in a sequence. And other than presenting and discussing these videos with the people when the community workers were visiting their homes, they were given, all the users were given a DVD where they had all the videos so they could see it whenever they wanted. They have a little booklet with some pretty basic stuff, because most of these elderly people have difficulties either concentrating or reading or visual problems. So anyway, in the app, we put in the videos. We had questionnaires to monitor mood changes, suicide risk, activity levels, because the main thing was a behavioral activation. We had checklists so that the community health worker would have to, before and after they completed the session, they were to fill in a little form. And it was a way not just simply of ensuring accountability of what they were doing, but it was also a way of training. Because when they see, they kind of, they remember what they were trained with and, what they should have done. Sometimes they don't do it. And then for the next patient, the next client, maybe they are more likely to do it. They had some basic information also kept in there, and it was shared with other members of the team. So that was it. The intervention went on. It was pretty large. I mean, these are some pictures you can see in here. There's a community health worker showing the tablet with the videos to a woman and a man. Most of our clients were women, by the way. And here it is. I like this picture because obviously the intervention seemed to have been tremendously effective, judging by her smile. But it's roughly, you get an idea of the real people. We did our pilot. The pilot was incredibly successful, I have to say, very small numbers, of course. But if you look at the intervention group, the drop in the PHQ-9 was massive. And we started our trial, and then guess what? These are the community health workers that they want to say hello to you. I love that. It's the human interface. So we were hit by the COVID, and then unfortunately we had to stop delivering the interventions at home. So we needed to think very quickly and fast. What do we do now? Because we really want to go on the second way of recruitment, and obviously we're not going to be able to visit these people. So the idea was, what about delivering the intervention in different ways? And so we did a bit of research. We tried different options, SMS, WhatsApp. In the end, WhatsApp proved to be the best platform to deliver the intervention. And so we have an intervention which is at the moment being delivered, but we've already recruited about 150 people. We need to get to 600, I think. So we have a set of messages. I think it's 18 messages, which are audio messages, because a lot of these people cannot see the screen or have difficulty with the screen. So we decided to do it with audio messages, but we also have a few other things that we can send them. And in fact, every week we send them a picture that summarizes more or less the ideas that were presented with the messages. So in here, that is what we call the virtuous cycle, which is one of the things that is all in Portuguese. For if there is someone in the audience that speaks Portuguese will understand, but it's just basically inviting people to do more things, and that gives you a little bit of motivation, you gain energy, you feel better. So we're in the middle of that. It was our reaction to COVID. Well, we're hoping for the best. We'll see. Whatever it is, it will be another way of delivering the intervention. This is slightly different. I'm going from one extreme of life to the other. just to show you that our interest in just kind of taking the life course. And essentially, these are preschool children in Chile. So we developed a game, which it was given to, it played in the classroom. And so you see the kids here in the classroom with their tablets. Lots of learning here for me and for many others. You'll notice that in every corner of the tablet, there is a little kind of colorful thing. These are kind of just to protect the tablet because the kids may drop it and break it. We had to buy special headphones because of issues around the decibels that were allowed. I mean, lots of learnings. But anyway, we did it. And it's a digital game that has allowed the kids to play to develop some cognitive and non-cognitive skill. We chose 4 of those: 2 cognitive, working memory and control inhibition, and 2 non-cognitive, which is emotion recognition and problem solving. There are 10 sessions, 20 minutes each. We did a pilot, and it was well received. Everybody liked it, the kids and the staff. Lots of things that we have changed. We would want to now test it in a fully powered randomized control trial, but we've learned, tons of things about how to do it better. But I don't have the time to tell you about that today. And then just to finish with the examples, just our stellar product where David and I work together with a bunch of people from Sao Paulo and Lima, Peru. So this was a kind of like a consortium of 4 universities. Northwestern was one of them, King's College and London School of Hygiene and Tropical Medicine when I was there at the beginning, and University of Sao Paulo in Brazil, and Universidad Cayetano Heredia in Peru. And essentially it was a platform that had 3 big pieces. There was an app that it was given to the clients. And so all the information, all the data that was gathered through playing the app was captured in the cloud, and then through some algorithms filter and relay to a dashboard that was held by a nurse assistant who had the role to check what was happening, if people were using the dashboard or not, if they were not, the app or not. If they were not using it, they had to sort of contact and find out, what the problem was and try to motivate the person to re-engage. Now, I want to mention this because I think this is really a really important piece that I personally learned from this experience. It's the role of the nurse assistant, which was more like a motivational coach, I will say. And there was another dashboard for the supervisor with, similar kind of information, but the supervisor would provide some support to the nurse assistant if it was required. So we did the one randomized control trial, and the other one, it was an individual randomized control trial. These are 2 massive trials, actually, in terms of numbers. So we had 880 patients randomized in Brazil, 432 in Peru. Now the intervention lasted 6 weeks, three sessions per week, very brief ones that it should be able to deal with that in 10 minutes each one. And we compared it with usual care, is basically whatever the people were receiving. The results were quite. I think they were quite promising, really, given that it was such a low intensity intervention. In Brazil, there was a drop of about 12.1 percentage points in the PHQ-9. This is a percentage points is in the recovery, and the recovery is less than 50, more than 50% reduction from the baseline PHQ-9 score at 3 months. And in Peru, the difference from baseline to the outcome was even larger, almost 19 points. Now, one thing to say, which is not shown in here, is that that we measure again outcomes at 6 months. And it wasn't that the active group had lost what it had gained. They continued, the percentages of people recovering was very similar. But for some reason, the people in the usual care were improving very rapidly. So at 6 months, there were no differences across group. You have to remember that the intervention itself lasted only 6 weeks. And then 6 months later, you measure the outcome. There was nothing in between. So like in many other interventions, gains usually fade away over a period of time unless there is something given. This is what I wanted to say, and I think the role of the assistant nurse was very important. The adherence that we achieved was incredible. I've looked at lots of other interventions, and what we achieved in Lima, it was incredible. 78% of the people completed all the sessions, the 18 sessions, and 92% completed at least 9, which is 50% of all the sessions. So that was incredible, to be honest. And I think part of it is due to the fact that there was this support in terms of increasing motivation, but I have no way to prove it. Lots of problem with using technology in low and middle income countries. As you can imagine, there is very little infrastructure in some places. Connectivity is very low, very poor. There is a lack of digital literacy and skills, and this is much more pronounced in certain subgroups, such as elderly people or poorer people also. Once again, we go back to the inequities. Lack of funding to purchase licenses, virtually no evaluation, very few, although this has been increasing, and very little, virtually no implementation. Privacy of information is becoming a bigger and bigger issue with time, and there is a lot of mistrust for reasons that you all may know. I put cultural adaptation with a question mark because I think things probably they do require, and we do look at language and certain things that can make it more attractive and appealing to our population. But I'm not completely convinced that the product that is developed in other places may not be used in a different setting with minor adaptations. I mean, I could be accused, this is a slightly provocative, but if you think about, there's so many things that have been, to begin with, products like, Microsoft and platforms, Google, Facebook, and so on and so forth that, are widely used all over the world. I mean, it's slightly different when you're dealing with a mental health issue, probably. Yes, I accept that. There are things, you may be accused of, kind of sort of imperialism, but, things like, products that were transferred, like, Sesame Streets became very popular in Latin America. All the Disney World became very popular, Yes, I mean, it's an imperial penetration, you might call it. But, sometimes I feel that, you need to bear in mind that, it's better to have nothing or something which hasn't been really intensively culturally scrutinized. COVID brought a window of opportunities. I'm coming to the end. Of course, there has been a much faster progress in most low and middle income countries, mainly for remote services, live interventions. And I keep on going back. Yes, and where how things are going to pan out after the pandemic, it's just to be seen. But my impression is that there is a lot of space that has been gained through the unfortunate COVID. And I think we should try to make the most out of that. How far can we go? Well, I want to say that there is, with everything in life, there is a negative and a positive side. On the negative side, I will say that to begin with, we can go as far as any rich country, but it will take a lot longer. And the speed of this process will depend on resources. Global inequities will grow larger, I think, although I'm not sure if that will be the case. But I have the impression that, there is, there will be less resources in the coming years, especially in low and middle income countries. There are so many needs that need to be catered for. Infrastructure and digital skill formation will continue to be a challenge, but less so with time. There are so many people who are quite fluent and quite good at doing things with technology in most countries. You go to Africa and you would always find a kid that can do things. Profit-making product might hinder the speed of transformation, and definitely will invite an industry of piracy, which is something that has already happened with software. But these days, the software has taken a different route in terms of commercialization. On the positive side, I think, the lack of health services in most low and middle income countries gives a lot of room to innovate in ways that rich countries will not allow. And that's shifting, as I mentioned at the beginning, was a very good example of that, and how knowledge could have flown much, easily to richer countries, and perhaps, things would have been quicker. There are, lots of platforms like Google, Facebook, WhatsApp, Instagram. They're all free and widely used in Lagos, Nigerians, and anywhere you go. So there is an issue around in making these tools accessible to people, and then they may be, in the long run, they may be a massive gain for those who are prepared to invest on that. There are other things that I know there are lots of companies that are interested, which is to do with a lot of data. 90% of the world population live in low and middle income countries. But beware that the issue of privacy is becoming a very big issue in most countries around the world, poor or rich. And I think with that, I finished exactly 45 minutes. Thank you very much for your patience.
Well, thank you, Ricardo. It was really great to see kind of an overview of what you've been doing in digital mental health. I see we're starting to have a few questions. I neglected to say, please put your questions in the Q&A, and we'll go ahead and read them off. I have a few, but why don't you go ahead and get started, Andrea? You can start asking the questions here.
Sure, and thank you for an incredible talk, so thank you. This question says, if you were to redesign remote delivery of chronic care and mental health management in telemedicine, what would be the delivery design that you would recommend, including the team structure?
If I were to redesign, what if I were to redesign the services that paramedics deliver?
The remote chronic care and mental health with telemedicine.
Okay. What would I redesign?
Like, how would you structure the team, and how would you think about doing, if we could redesign all of it with in telemedicine, how might it look different?
Well, I think, I think to me, one of the biggest challenges that we're facing is integration. Integration, not only across topics, services, but also technologies. So, there are people, choices that people can make, and people, don't want to see you or don't want to talk to you, prefer to work on their own. Well, maybe they can do that. And integrating all of that, A lot of people come to us on mental health through different routes because there is so much stigma and stuff, so integrating, using other platforms, which is something that we've been doing. In fact, CONEMA was, I don't know if you noticed that, but it was a program that was integrated in program for hypertension and diabetes. So these were people that had hypertension or diabetes, and on top of that had depression. So that level of integration, I think, is really important. And whoever goes there first, to be able to integrate a massive platform that covers everything, that's the winner.
Thank you. And we have a second question saying, thank you for your great presentation and the work you do in our countries. I am originally from Paraguay, and I wonder what your thoughts are about using technology to screen for mental health problems like depression in primary care in LMICs in Latin America. Given the lack of resources, how useful do you think it would be to improve the workflow of primary care settings?
Yeah, that's a great question, actually, because I didn't show you that. But one thing we did in Peru is that we developed an app, which was just simply for Screening Plus. We call it Screening Plus, because I think, there is an ethical issue. If you don't have anything to offer, you shouldn't screen. So we call it Screening Plus, and it was essentially an app with a questionnaire, simple questionnaire, the one that the Ministry of Health in Peru was using, and with a threshold, and then we gave it to a lot of people working in chronic care clinics, hypertension, diabetes, musculoskeletal disorders, you name it. And so whenever a person came to the clinic, the receptionist will ask them, would you mind to do this thing? And if the person scored above a certain threshold, they will, the nurse will get a quick message saying, this person scored above a threshold, just, keep a note. And then the person will start receiving messages. The first message will be, if you want to do something about it, this is where you have to go, because we had a system to geographically locate the services, the mental health services that person could go for. And so we would send them that, and then there will be messages reminding them that they should go in there. They will get a little note on the message, which was a referral note that they could present it to the doctor if they went to a place. And then we look at the people like 3 months later. We went back. And I couldn't believe it, but like 60 to 70% of the people had been seen in a country like Peru that virtually doesn't have any mental health services. So somehow that very simple screening intervention was enough for people to at least see and talk to somebody about their mental health problem.
That's awesome. Thank you. We have one more question come in, and then David, you could jump in too, which is, have you done any pilots with college students? And if so, what have you learned? You talked about the whole spectrum of ages.
Pilots of what?
University students, college students.
Yes, we are at the moment working on that. In fact, we have a project in Colombia at the moment, which is a fantastic project because we've partnered with an organization that gives I don't know if you heard of the concept of cash transfer. It's a cash transfer program. It's an organization. A cash transfer is basically if you join this organization, which is going to help you to get further education, you receive a certain amount of money provided you comply with certain, they're called conditionalities. So there are certain conditions that you have to meet, which is essentially attending classes and so on and so forth. So this is a program, a massive program in Colombia. They've got about 40,000 kids in this program. And then, so we are kind of sort of screening, these are all further education students. And we're trying to do something with them. We haven't started yet the intervention. So we don't know what's going to happen. To be seen. It's not easy to work with a university student, by the way. There are lots of things, lots of issues. You need to be aware. I mean, first of all, working with the educational sector, because I've done trials in schools, it's a completely different sector. You need to learn new rules. It's like sort of moving to a new country, really. You have to learn, how to talk to. I mean, you have to learn everything. You have to be reborn, to persuade teachers, that are, we were talking about community health worker being overloaded. Look at the teachers, having 300 things a day, they receive that. They have to deliver programs. The same thing happens in universities, but the students are less protected in a way because they're adults. So we don't know, but there are quite a few people doing things. I know that Ron Kessler in the US is doing something in Mexico and Colombia. And there are a bunch of people here in Europe that are trying to do stuff on that.
David, I'm going to jump in with this last one because it's a fantastic question and I think really well suited to the work and your expertise, which is, first, they said, great presentation, thank you. And the question is, can you say more about what happens when a successful study is done? How can we better encourage longevity of successful interventions outside of a research structure, especially when these require training, tablets, headphones, etc., resources?
Wow, that's a fabulous question, actually. I think that's a question that David will give you a talk for 1 hour. He's a lot better, he's much better qualified than myself to talk about that. But David and I share that interest that, in order for something to be implemented at a larger scale, one of the things we have failed abysmally is in thinking about it. How would this thing, is it possible to implement this thing when you're at the stage of designing? And what would be the potential obstacles that I'm going to be facing? Do not design anything that doesn't at least have face validity that it is potentially scalable, because it will be a waste of time and money. So it's essential to think about that, and it is essential how you're going to fit in this thing. David has written lots of papers about embedding things. That's how do you embed these things? And you need to think about the multi-level kind of thing, because there is a user, there is a provider, there is a system. There are lots of things in there. The interplay of all these factors, will determine in the end whether or not you can sell it. Don't forget the politicians, they're essential.
Well, maybe that's a good, I have one of the things that I was curious to ask about kind of follow that this last question kind of gets to it. And one of the things that I was, really impressed when we started working in Brazil and Peru was, you make contacts with the ministries of health at really the highest levels, and there were meetings with them, before the earliest stages of planning. You were already, engaging with the health systems to try to understand them, to understand what their needs were, how they eventually, if successful, how it could be rolled out. So there's ways in which, you start planning for this at the very beginning. And I wonder if you can talk a little bit about, some of the things when you're doing that you're looking for, what you're thinking about. I mean, how do you think about that process? Because you have been successful at, it's very few, as you pointed out, very few of these actually do get implemented as in the processes of care. And you're one of the few people that's actually achieved that. So maybe you can talk a little bit about kind of what you think about at those earliest stages and how you begin that planning.
Yeah, well, I think it's a critical level, because to me, if you are interested in services for the more socially deprived populations, that's something that only the governments are prepared to deliver. So your buy-in, the person you want to sell this thing is the government. It is an essential one. I'm not saying the private sector may not have an interest. They might come in. We have been able to bring in foundations to but our interest is in socially deprived populations. So I have to say that in the case of Chile, you know, one of the key things for me was that I work at the ministry. I worked at the ministry for 3 years. So I knew very well how things are done, how decisions are made at the ministry. So I knew that, you know, mental health wasn't a very key, it would never be prioritized, or so that I needed to find some ways of, you know, kind of sticking in the product in a different way. So I knew that probably you needed to go to approach partners that had more, you know, power, that could leverage the product and convince the major stakeholders, the one who decide the budget. So I knew a lot of these things from my time at the ministry. I have to say that a lot of things that I learned when we were introducing these things, you know, things like, for instance, you know, that you may think it's not a key thing, but it was. I mean, I learned through actually talking to people, you know, like the program, we decided, you know, it wasn't a good idea to introduce the program through the mental health department, but it was a much better idea to introduce it as something from primary care, primary care. So we gave the program to primary care, ready to be implemented. And because primary care is a big thing at the ministry, and they have a big budget. And so they said, you know, when we went there and said, you know, well, this is like, you know, music to our ears, you know, because you're coming with the same idea. This is what we do in maternal health with the midwife. This is what we do in pediatrics, you know, with the nurses. And then here you come with these things and you're saying you're going to bring in psychology. It's okay, well, it's the same sort of thing, you know, it fit in with our idea. So it was very important to create that alliance, that partnership with the powerful players, you know. Another thing that I thought is very important, and I just never stop saying to people, you know, and I've been discussing this with my friend Dixon, because I think what it is essentially is that you have to find the end game is not just simply implement it, but make it sustainable and effective, successful. But to make it sustainable, you need to think, how can I, you know, because, you know, politicians change all the time, you know, the ministers, you know, they don't last, in some places they last month. And, you know, they can be removed. And the answer to that thing, the head of primary care told me immediately what I needed to do. He said, you need to institutionalize this. You need to make it part of the budget. And if it is part of the official budget at the ministry, it becomes law. And it will be almost impossible to dismantle after that. And that's exactly what we did. And, you know, I don't even know if it is being effective or a good investment for the country now, but I'll tell you, it's going to be, you know, pretty difficult to dismantle this thing.
All right. Well, I think we're at the top of the hour now. So, Ricardo, thank you so much for a great talk. And, you know, I hope we are able to see you again soon.
Yeah. Yeah. You just have to jump across the pond. We'll be waiting for you.
All right.
All right.
Thanks very much. Thank you, everybody, for attending. We'll see you all next month. Bye-bye.
Bye.